Hello, everyone. Welcome to the Ohio Program for Campus Safety and Mental Health webinar. We are so happy to have you all joining us. My name is Russell. Before we get things going, we just want to have a couple of brief announcements. One thing I want to let you all know is that about a few months ago, we surveyed folks on our listserv for topics of interest. And we've really tried hard to meet, based on the past 4 or 5 webinars, really meet your requests. And mental health and academic success in college was one of the topics that you all expressed a lot of interest in. So we're happy to be able to meet that need. And probably going forward, perhaps in May, we're going to send out another survey to you all just to kind of get a sense of what topics of interest you all have, and we'll try our best to find experts who can present on that. I'm going to kick it over to Jessica for a moment.
Sure, and thank you all for joining us today. I just want to actually update you on a few things. First and foremost, we are excited that registration is open for our fourth biannual conference, Raising Student Voice and Participation. That will be held on Tuesday, May 21st at the Quest Conference Center in Columbus, Ohio. So once again, registration is open for that. And then also, we invite you to join us on Wednesday, May 22nd, where Dr. Juanita Martin from the University of Akron will present our next webinar topic on the best practices for engaging African-American students in higher education.
Without further ado, y'all didn't come to hear us blabber off, so I'm going to do a brief introduction, and then we'll get into the presentation. So Dr. Sarah Ketchen-Lipson is an assistant professor in the Department of Health Law Policy and Management at the Boston University School of Public Health. She's also associate director of the Healthy Minds Network for Research on Adolescent and Young Adult Mental Health and co-principal investigator of the National Healthy Minds Study. Sarah completed a dual PhD at University of Michigan in Health Services Organization and Policy at the School of Public Health and Higher Education at the School of Education. So Dr. Lipson, thank you so much again. This is the second time that she's presented for our Ohio Program for Campus Safety and Mental Health. Earlier was our November convening. So thank you again, and you can get started.
Awesome. Thank you so much for having me, and I'm so thrilled that there's a lot of interest in this topic, which doesn't surprise me. I think that as I'm going through and talking about kind of the connection between mental health and academic success, I'm going to be framing this as sort of one of the most effective ways that we can be arguing for the importance of investing in mental health on campus. So as Russell said, my name is Sarah Lipson, and I'm an assistant professor here at the Boston University School of Public Health. And I do research on mental health and mental health service utilization among college students. So today I'm really looking forward to sharing some of my research related to the relationship between college student mental health and academic success. So before launching in, I just want to give a quick overview of how I'm going to approach this. So I'm going to present for about 50 minutes, 45 to 50 minutes, and then there'll be 10 to 15 minutes for Q&A, as Russell mentioned. And the webinar is being recorded, so that will be available later. And I just really welcome the opportunity to be able to engage with all of you about this topic. And we'll see that it's a complicated one, and I think one that is really important. So let's jump right in. All right, so this is kind of the spoiler alert slide. The main takeaways of this talk today are as follows. Mental health is strongly associated with negative academic outcomes. Note that I'm going to say associated here rather than trying to make a causal argument. There's really a need for more rigorous study designs that can make these causal claims about the impact of mental health on academic performance, but we don't quite yet have that evidence. And so the evidence that I'm going to be talking about from our Healthy Minds study are using longitudinal data primarily. And so in the work we've done with the Healthy Minds study, the evidence is incredibly consistent. And every time that we've replicated these analyses, we found that mental health problems are associated with lower GPA and higher rates of dropping out or stopping out of college. So I'm briefly going to describe the Healthy Mind Study in just a moment, but for those of you who know, you know that the Healthy Mind Study is a large-scale national survey, and without exception at the schools where we've looked at this relationship, these have been the findings. I'd actually go so far as to say that this is our most consistent finding, and by that I mean it's one we've replicated at different types of institutions, and the findings are always the same. So I'll get more into the numbers and how we've looked at this relationship shortly. The next takeaway is that the link between mental health and academic performance and persistence is not widely recognized. So there's a national dialogue and has been for quite some time about retention in higher education, but this dialogue centers more around some other very important issues, such as academic preparedness and financial stress. But mental health is another key factor that we need to be considering and bringing into this dialogue. So my hope is that this webinar will allow you to understand this relationship and hopefully be able to articulate this and pass along this information in your work, because I think this is a powerful case for investing in student mental health. So that leads me to my next point, which is that there's a strong economic case to be made for investing in mental health treatment and prevention efforts on campus. Particularly for tuition-driven institutions, the return comes in the form of tuition dollars that are retained due to dropouts that are averted. But on all campuses, there's the potential return on investment that comes from students who feel supported by their institution, both in terms of individual well-being, and then for the economists in the audience, how this might translate into, say, alumni giving and donations down the line by students. So relatedly, I think we need to be comfortable, even as people who come into this work because of a desire to help people. I know that's my own kind of perspective. I'm not an economist. My colleague Daniel Eisenberg is. And I think before I really started in this work, I would have maybe had a perception that an economic case is, you know, can't also incorporate a real prioritization of student well-being. And so I think I really hope that we can think of these two things together. And so that the economic case and, you know, our own, you know, passion for student well-being are kind of one and the same, and we'll get there if we're thinking about this lens. So as a field, I think we can and we need to be articulating this economic case as one of the main reasons that colleges and universities should address student mental health. So those are the main takeaways. And so in essence, the economic case looks something like this. So this is somewhat of a theoretical relationship depicted here. We can logically think about the economic case in the ways that are shown here. Some of these relationships our Healthy Minds team has explored, and some have been explored by others, such as how every year of college is associated with increased lifetime earnings. So that's in the middle row in the right icon. We haven't done that work, but that's well established. The logic is this, and it's shown here for depression. Reducing depression, say through being able to provide resources to more students more effectively and efficiently because of new investments in the counseling center or wellness center or some other unit on campus, will lead to increased student satisfaction, increased retention, and increased lifetime earnings. This will lead to increased alumni donations and higher graduation rates, which boosts institutional reputation, and will lead to increased tuition dollars due to increased retention. And then there are personal benefits to students and societal benefits in the form of a productive society and lower downstream consequences and costs of mental health disorders. And we all are likely aware of the fact that the college years coincide with the age of onset for many lifetime mental illnesses. So we're going to dive much more into kind of the relationships that are represented here, but first I want to provide some context about college retention and mental health on campus. This figure is from a Chronicle of Higher Education report. The report is based on a survey of 112 presidents and student affairs leaders at 2- and 4-year public and private institutions. This survey asked respondents to identify two major concerns outside the classroom. Overwhelmingly, 66% identified student mental health as the top issue. It far outweighed the next most serious concern, diversity and multicultural issues, which 40% of the respondents identified, And as I'm going to talk about a little bit later, these two issues, mental health and diversity, are things that we also need to be thinking a lot about together and not as, quote, separate issues. One other point I'd like to make about this chart here is that it is titled outside of the classroom, which implies that mental health is not something that affects what's going on inside the classroom. And this is sort of the implicit way in which mental health is being left out of the dialogue about academic performance and retention. There are a number of really important and innovative developments with regard to trying to help students stay in college and complete their degrees. Things through first-year advising, first-year experience courses, learning communities, and academic and social support. These efforts point to the national dialogue around student retention, which is, for the most part, about helping students succeed in the classroom and secondarily have social connections on campus. These are amazing and necessary initiatives, and there's truly some very exciting work being done in these areas, but mental health is largely missing from these conversations. And that's actually somewhat surprising, given that the national attention to what many refer to as the campus mental health crisis. And so we see the campus mental health crisis, these words used in the media now more than ever. And I think the attention towards the campus mental health crisis inevitably has good and bad sides. Sometimes I worry about the fact that same-age non-college students are actually experiencing the same rates of mental health problems as college students, but they're getting less attention. And this has been shown in many national surveys that those rates are similar. But we can't change the fact that college student mental health is increasingly recognized as a major problem. And on the great side of this, or the opportunity, is that there are really unique opportunities to address mental health on college campuses, given the infrastructure of higher education and the fact that 70% of all adolescents and young adults are enrolled in post-secondary education in the US. So in this case, we're thinking about how attention towards college student mental health can be leveraged to create change on campus. So as I mentioned in the takeaways a few moments ago, mental health is largely left out of these discussions around student retention. This is actually also interesting, given that the origins of student retention theory and research were kind of had their roots in mental health. So Tinto's model of student retention, which is widely talked about in higher education and in other fields, was actually based on Durkheim's theory of suicide. And at the core of both the theory of suicide and Tinto's model of attrition, the focus is on the importance of social connection. Without social ties, there can be negative consequences in the form of suicide and college dropout. So it's interesting that mental health is not one of the main things that we're talking about related to student mental health. It's interesting that it's not actually one of the kind of initial things that we're thinking about, given that the roots are actually in this theory. So now let's turn to empirical evidence with some findings from the Healthy Mind Study. We're going to look at findings from the Healthy Mind Study, but first I want to underscore why college students are an important population for thinking about mental health and how the campus environment offers a unique opportunity for intervention and prevention during a pivotal life period. So why are college students an important population to consider? There are many reasons. In one of my favorite TED Talks, Dr. Tom Insel, who's the former director of the National Institute of Mental Health, referred to mental health disorders as the chronic diseases of the young. That phrasing has really always stuck with me. Whereas most physical health conditions onset later in life, 75% of lifetime mental illnesses onset by age 24. Also, unlike physical health conditions, most people who eventually seek treatment for mental health disorders do so after significant delays. The average time from symptom onset to first treatment contact is over 1 decade. This is a missed opportunity for early intervention. The percentage of young adults aged 18 to 25 with any mental illness who received mental health services was lower than those ages 26 to 49 and 50 or older. Just 38% of 18 to 25-year-olds with a diagnosable mental illness received treatment in the past year. My work focuses primarily on college student mental health. In recent years, this increase in interest in college student mental health has been very interesting, as I'm sure has been the case for so many of you out there in this field. There are over 22 million students enrolled in U.S. post-secondary education, and the college years are a very important time for psychosocial development, and mental health is a very important predictor of long-term economic, educational, and social outcomes. So these are the factors that motivate my work and the work of my colleagues and I who conduct the Healthy Mind Study. To date, about 300 colleges and universities have participated in the Healthy Mind Study. Colleges and universities enroll in the study, so this is not a random sample of institutions, though we do have a diversity of institutions, including community colleges. Most campuses are in the US, but there have been a handful of Canadian institutions, as you can see in this map. There's also a different set of institutions that participate each year. So these are the things to kind of keep in mind as I'm presenting the data. The Healthy Mind Study team is at University of Michigan and Boston University, and we have an amazing team who's really working so hard on this study and doing incredible work. So before I dive into the study, I just want to orient us a bit by saying that the Healthy Mind Study is a population level survey, meaning that it's completed by all students, not just those students with a diagnosis or who are receiving mental health treatment. So now let's turn to the specifics of the survey. HMS is an annual survey. It's conducted entirely online and it's hosted on Qualtrics. At each campus, we recruit a random sample of 4,000 students to participate. And at smaller institutions, we invite all students to complete the survey. Recruitment is done entirely by email, and the sample includes both undergraduate and graduate students. The survey takes about 15 to 20 minutes to complete, and after completing the survey, students are provided with a tailored list of mental health resources, both local and national. Response rates are about 20 to 30% depending on the school. So this is obviously another limitation to have in mind as I present the results. So first, let's turn to the mental health measures and then the prevalence of help-seeking. So an important strength of the Healthy Mind Study is that we're measuring mental health using validated measures. We'll focus on a number of these today, including depression, anxiety, eating disorders, and behaviors of non-suicidal self-injury and suicidal ideation. We'll also talk a little bit about flourishing. It's very important, and I think related to our work, to really remember as researchers and practitioners that mental health is on this continuum, and to not only be talking about mental illnesses, but also the other end of the continuum. I think we have a lot to learn from the many students who are flourishing or thriving on campus. So there are two statistics that I hope are going to orient us further. First, the high prevalence of mental health conditions shown on the next slide. And second, the low rates of mental health service utilization by college students with apparent need. So roughly 1/3 of students have an apparent mental health problem, either depression, anxiety, an eating disorder, or they report non-suicidal self-injury or suicidal ideation. So these are positive screens, not diagnoses. All combined, 35% of students in the aggregate National Healthy Minds data meet criteria for one or more of these conditions. On the right, you can see rates of past year treatment, defined as any therapy or psychotropic medication, among students who meet criteria for one or more of the conditions in the graph on the left. The bar on the far right shows that less than 40% of students with apparent need have received any treatment in the past year. The mental health treatment gap, the proportion of individuals with an apparent mental health disorder who are not receiving care, is over 60%. And most students who do seek help do so in a crisis, which puts a strain on the campus mental health system. And this is true in other populations and settings and points to a need for promoting help-seeking and early intervention. Even among students who do receive care, it's often inadequate. In one study led by my colleague Daniel Eisenberg, they provided the first known evidence on the adequacy of depression care among college students and how this varies by subpopulations and provider types. They estimated the prevalence of minimally adequate treatment among students with significant past year depressive symptoms. Minimally adequate treatment was received by only 22% of depressed students. The likelihood of minimally adequate treatment was similarly low for both psychiatric medication and psychotherapy. And minimally adequate care was lower for students prescribed medication by a primary care provider as compared to a psychiatrist. Racial and ethnic minority students were also less likely to receive any form of depression care. And the main conclusion that I want us to take away here is that the mental health treatment gap on college campuses is also experienced by students who do receive some form of care. And as I'll emphasize later, the solution is not simply putting more providers in counseling centers. I definitely don't want people to come away from today's talk thinking that the investments that we need to be making are just, continuing to put more and more providers in counseling centers. We all know that's not going to work. So I just want to pause to synthesize the past few slides. And these, I think, are the biggest things to keep in mind as we're just about to dive into the connection between mental health and academics and the data. So we have a high rate of mental health disorders on college campuses, and most students are not receiving needed services and resources. So now let's look at what the Healthy Minds data say about the connection between mental health and academic outcomes. My colleague Daniel Eisenberg and I looked at the relationship between mental health and academic performance, focusing on students' academic experiences and expectations as interrelated mechanisms. So here we find significant differences by mental health status, including that 1 in 4 students with symptoms are dissatisfied with their academic experience relative to 1 in 10 students without. Approximately 35% of students with symptoms doubt whether higher education is worth their time, money, and effort, compared to 15% without, so half as much. In multivariable models, mental health problems were a significant predictor of academic dissatisfaction and dropout intentions, while positive mental health or flourishing was a significant predictor of satisfaction and persistence. Here you can see how students responded to the item, "I am confident that I will be able to finish my degree no matter what challenges I may face." You'll see that 30% of students with depression strongly agreed relative to 56% of students without depression. Our team has also looked at this relationship longitudinally. Through our Healthy Minds study, we looked at how student mental health, as reported in the web-based survey, correlates with academic outcomes. And we've done this by linking survey data to institutional data through the registrar's office, such as GPA and retention. Consistently across campuses, ranging from large public institutions to small private art schools, students with mental health problems are twice as likely to depart from the institution without graduating. And this is even after controlling for prior academic records and other student characteristics. In the data that I will present here, the findings are from a single institution. The full citation for this paper is listed in a slide that I have at the end of the presentation. As background, the study was looking at mental health and academic outcomes over a 2-year period among undergraduate and graduate students. The outcomes were GPA and institutional retention, and the exposures of interest for symptoms of depression measured by the Patient Health Questionnaire 9, anxiety measured by the PHQ anxiety module, and eating disorders measured by the SCOFF. So let's take a look at the GPA and retention findings. Looking at GPA within a single semester, so cross-sectionally, the data showed that depression was associated with lower grade point average. Looking at the PHQ-9 depression scores, which ranged from 0 to 27, and average GPA for each point on the scale, the findings were as follows. Going from mild depression, like a score of 5 on the PHQ-9, to severe depression, so say a score of 20, was associated with -0.2 in GPA, and if depression and anxiety were co-occurring, this was associated with -0.4 points in GPA. So these differences in GPA, they are modest in absolute terms, but they represent respectively 0.3 and 0.7 standard deviations in the GPA distribution. And they would lower a student with the 50th percentile GPA at this institution, so a GPA of 3.61, down to the 37th and 23rd percentiles respectively. By contrast, anxiety in the absence of depression and eating disorders are not significantly associated with GPA within the semester. So now let's look at GPA and mental health over 2 years. The analysis of GPA over time only applies to people who were surveyed in both baseline and the 2-year follow-up. Depression, panic disorders, generalized anxiety, and eating disorders are each associated with lower GPA over time. When we look at interactions between mental health conditions, we see that co-occurring depression and anxiety has a negative and significant association with lower GPA. The PHQ-9, that actual measure of depression, has 9 items which measure the 9 core symptoms of depression, And so we looked at each of those specific symptoms. And of the 9 survey items, it was lack of pleasure and interest in usual activities that had the strongest negative relationship with GPA over time. And I know I'm presenting a lot of data here, so please be thinking of questions that you have, and I will be very happy to address them. So now let's turn from looking at GPA to looking at retention. So this slide shows a comparison of dropout rates among students with low GPA, so that's less than a 3.0, that did and did not have symptoms of a mental health problem. 25% of students with low GPA and mental health problems dropped out, compared to 9% of students with low GPA and no mental health problems. So the implication of this, and I'm going to get into this even more later, is that to identify students at risk of dropout, campuses are often relying solely on low GPA in the previous semester as a criteria. And I'm going to talk about what this means in practice and how we might be thinking about how mental health as well as GPA can be used to identify at-risk students. The findings here are consistent with other studies that have been done. So the College Life Study, for example, has examined the relationship of mental health problems with risk for discontinuous enrollment during college, defined as a gap in enrollment of 1 or more semesters. And they have found that mental health problems have predicted discontinuous enrollment. Importantly, students entering college with a pre-existing psychiatric diagnosis were not at additional risk for enrollment interruptions in the College Life Study. As I presented, 25% of students with low GPA and mental health problems dropped out, compared to 9% of students with low GPA and no mental health problems. To identify students at risk of dropout, campuses are, again, relying mostly on low GPA as their criteria. In our study, we found that GPA alone would identify 11% of students who eventually dropped out from the university, while using low GPA and mental health problems would have identified 30% of dropouts. This suggests that efforts to anticipate dropout could be more efficient if based not only on low GPA, but on the combination of low GPA and mental health symptoms. So here's a graphical representation of this relationship, which our colleagues at Cognito worked with us to develop. As a researcher, I'm very deeply committed to translating research into practice. That's why I'm so excited to be talking to you today. And for those of you who I've met, you kind of know the type of work that I do and how I'm maybe not a traditional academic in a lot of ways. And so I think that the relationship between mental health and academic outcomes is one of the most important aspects of the work that our team is doing in trying to translate research into practice. So the big question is, how do we take this knowledge and do something about it? First, I want to say that it would be very easy for me to say, just invest in more counselors. That's sort of the most obvious thing. But the supply is never going to meet the demand. We need a public health approach. We need to be spanning from universal prevention to clinical treatment. And we need an efficient mental health system, which is a very complicated thing to think about and even more complicated to enact. But with that said, I want to turn to thinking about what investments can be made, including but not exclusively by increasing mental health providers on campus. So let's look at how this translates into an economic case. This is another version of the logic of the economic case that I showed earlier. So I know I went over that quickly, and so I'll pause here. So what we're seeing here, the kind of logic behind this image is that reducing depression will increase retention, leading to increased revenue through tuition dollars for the institution and other benefits to the institution through increased student satisfaction and institutional reputation. And then the benefits to students and society associated with increased well-being and lifetime productivity. So now let's look at some numbers that can kind of go behind this logic. The numbers presented here are based on assumptions that are behind the boxes that were in the image on the previous slide. So for example, in terms of the amount of earnings associated with each year of higher education. And I guess in addition to questions that folks have, and maybe this is more of a follow-up and you'll have my contact information, but we're always looking for ways to be able to improve the way that we're explaining this. So here goes again from the top. This slide in particular, I think, is incredibly important. So there's assumptions behind the boxes that are here on this slide. And this is what's on this slide now is a very simplified version of the economic case, just to start us off with. And I will also say that the benefits are different for tuition-driven and non-tuition-driven institutions. So as an example, we can consider a hypothetical program that would provide mental health care for 500 depressed students in a year. This could be hiring a handful of new clinicians at a counseling center or of course, prevention and other approaches. Based on standard estimates, the cost would be no more than about $500,000. So it's about $1,000 is sort of a generous estimate of the treatment costs per student. Taking into account Healthy Minds data and other research on the effectiveness of mental health care and the economic returns to education, we estimate that this program, this investment of $500,000, would yield approximately $1 million in additional tuition revenue and over $2 million in lifetime economic productivity for students. So this means that the return on investment on mental health services or preventive programs with comparable effectiveness is estimated to be $500,000 from a narrow institutional perspective and $1.5 million from a general societal perspective. And note that this economic case does not even account for the most direct benefits, which are boosting well-being, relieving suffering, and potentially saving lives. Again, this is a simplified case, but the ratio of 1 to 2 to 4 in terms of investment to return to institutions, to students, and to society is what we should really be taking away from this. Our team has also developed a return on investment calculator that's customizable. So to assist campus leaders in advocating for additional investments in student mental health, our team created a simple return on investment calculator for estimating these economic benefits personalized to your school. So the online ROI tool has parameters that are customized. These include the school's population size, retention rate, prevalence of depression, and alternative assumptions about the effectiveness of a new or enhanced program or resource in improving mental health. So your proposed services or programs could be focused on mental health treatment or could also seek to prevent mental health issues. They could be new or expanded offerings that your campus is considering, or they could be existing services. In terms of how to use the ROI calculator, if a campus doesn't have all of the data about its student population, so for example, the proportion of students with a positive depression screen, the ROI tool is kind of pre-populated with our national averages from the Healthy Minds study. And then of course, all institutions are welcome to participate in the Healthy Minds study. And we would love to work with you in that way if you're interested in collecting the data, but that shouldn't be a barrier to being able to, in some ways, use this ROI. These parameters are then plugged into the automated ROI tool to estimate the expected return from a new investment in student mental health. This, again, could be treatment or prevention in terms of tuition dollars retained as a result of averting mental health-related dropouts. We've seen many campuses participate in the Healthy Minds study to assess the mental health needs of their student population and then combine these data with our ROI tool to understand the economic returns to the university from specific mental health investment. The ROI calculator is an online tool that can be used to explore the economic benefits of investing in student mental health. And we've recently worked with the American Council on Education to update the ROI calculator. And it's much snazzier and even easier to use. And that's going to be available soon in a new interactive format. So I also just want to pause and say thank you to my colleagues Peter and Shelby and Sarah for their work on this project with me, as well as Holly Chessman from ACE. And once this resource is available, we'll be making an announcement over the Healthy Minds listserv, which if you're not already a part of that, I'll have a link at the end of the presentation if you'd like to sign up. So what are the real implications of this research, kind of the so what question? Addressing college student mental health is crucial for the overall social, educational, and economic well-being of students, institutions of higher education, and broader society. Mental health struggles interfere with students' academic success, lowering GPAs, leading to discontinuous enrollment and often dropout. Investing in student mental health will result in academic and economic benefits for institutions and society. So what are the ways that campus leaders can use this and take action? And I think this is not an exhaustive list, but are some of the things that my colleagues and I have been thinking about. So speaking out, normalizing mental health and help-seeking is something that campus leaders can do. Pursuing partnerships to ensure a campus-wide comprehensive approach to mental health care promotion and prevention. Investing so that services and support programs are accessible, affordable, and tailored to the needs of diverse students. And I'm going to talk even more about the real need to be thinking about that in particular. And then listening and responding to student needs. I also want to underscore that all campuses can take action to prioritize student mental health, even with limited resources. So assessing student needs can be done systematically by collecting data through a population level survey or through listening to students more informally. Policies, programs, and services across campus are impacting student mental health. We know that, and we need to comprehensively assess existing efforts and identify gaps. Healthy Minds data show that students of color, first-generation students, LGBTQ students, international students, and low-income students face unique mental health burdens and barriers to care. And low-income students face unique mental health burdens as well. Having diverse student perspectives inform mental health practice and policy on campus is really essential. We need to be considering opportunities to integrate mental health promotion and prevention throughout the campus system. So in the classroom, through curriculum changes, and through faculty and staff training. Several campuses have been successful through creative partnerships with stakeholders on and off campus. Other examples of opportunities to invest in student mental health include suicide prevention, education and awareness programs, peer support programs, screening and linkage initiatives, technology-based services, and curriculum-based programs, including things like resilience building and coping skills courses. The next point here is enhancing the accessibility of clinical services. Consider addressing the costs. The college presidents have been able to reduce fees for mental health services at many campuses. Service location, embedded counselors we know make clinical expertise more local. They can be embedded within a school at a university or college within a university or residence hall. And then we need to be thinking about the range and volume of available services. Finally, there's an overall need for campus leaders to set the tone regarding mental health on campus through proactive messaging, communication, and norm setting. Next, I want to turn briefly to something that deserves a lot more attention than I'm going to be able to devote to it in this webinar, but I do want to make sure we touch on it. As you may know, much of my research focuses on mental health equity on college campuses, and I'm particularly interested in understanding and addressing disparities experienced by students of color and gender minority students. The main point that I want to make here, briefly, because it's beyond the scope of this particular webinar to focus on this at great length, is that campuses today are more diverse than ever. Our investments to support student mental health the investments that we're making to support student mental health need to recognize this. Recognize that a one-size-fits-all approach is not working and it's not going to work. Students of color, for example, are less likely to seek care. We need new approaches and resources to support these students. My colleagues at the Steve Fund have been pioneers in thinking about supporting the mental health of students of color. I encourage you to check out their work. And I did just want to take a moment here to say that equity needs to be not a lens through which we're seeing mental health on campus, but a necessity interwoven into every fiber of the work that we're doing on campus. So in this case, one important thing to think about is that students of color and first-generation college students, groups that are at risk of dropout and other adverse academic outcomes, are some of the same groups of students that do not seek care when in need. And I'd be happy to talk more about this in the Q&A. Also, our Healthy Minds website has some articles about this, about mental health equity and disparities, including our 2018 article in the Journal of Adolescent Health. So now let's talk briefly about the research that is still needed to understand relationships between mental health and college student academic performance. There's a lot more research that is needed on this relationship. We need more definitive estimates of the effects of mental health on college success. We need causal estimates through randomized control trials in particular. And this is really complicated to think about for a number of reasons, but there are opportunities that our team has been thinking about. We need to understand more about how these relationships vary across students' identities, particularly for students from backgrounds that have higher rates of college dropout. As I mentioned, students of color, low-income students, transgender students as well have lower rates of retention, and other groups as well. Another area where we need more research is on prevention and how this translates to returns on investment. This is a huge challenge in the entire field of public health, being able to show the returns from prevention work. And it absolutely applies here to the economic case for investing in student mental health on campus. So with that, I want to make sure that I'm leaving time for questions. So I am going to, for the most part, be wrapping up here. I'll say a few things about the Healthy Minds Network, which is the organization of the Healthy Minds Study and our team's other research. And as I'm doing this, please be thinking about questions that you have about the Healthy Minds Network or anything that I've presented today. So the Healthy Minds Network is a research to practice network. It's based at Boston University and University of Michigan. And we're taking this public health approach to mental health among young people. And with that context, we are, I would actually say a huge part of our research has been motivated by things that questions that practitioners have asked us that have allowed us to understand what our priorities in research can and should be. And really our objectives and our starting point is to be able to produce knowledge. So our starting point is with research. And then we're looking to distribute this knowledge through dissemination practices and translating in a way that practitioners and policymakers can actually use this knowledge to inform their work. So this sort of shows our overall team's research to practice agenda, and the economic case that I shared here is such a central part of this research to practice agenda. So at the bottom, you can see we're collecting descriptive population data primarily through the Healthy Minds Study. And then we're using that to design and evaluate programs and interventions. And the overarching question here is how can we invest most efficiently in the mental health and success and well-being of student populations? And then on the right, you can see we're really trying to get this research in the hands of practitioners, administrators, policymakers, and students. So we have a number of different strategies for data dissemination. We have a webinar series as well. We have research briefs. We have a data point of the month series, data reports. We have a data interface, which is, again, a resource that came from hearing from practitioners on campus who really wanted a way to explore the data interactively, many of whom do not have time or do not have a background in research to be able to work with a data set. So the data interface just allows you to use a simple drop-down menu to generate graphs. So you could say, I'm interested in the prevalence of depression by race, ethnicity, and then you click generate graph and it gives you a graph. Of course, the economic case analyses, the return on investment is a big part of what we're disseminating. All of the campuses that participate in the Healthy Minds Study, we actually run that ROI calculator for the schools and produce a one-page memo. And then we have an annual college mental health research symposium and partnerships with many incredible organizations nationally. So as Russell said, and I think as I also articulated, we will be sharing the slides from today's presentation. These are just two important and very relevant readings from the Healthy Minds Study looking at this relationship between mental health and academic outcomes, and all of our publications are on the Healthy Minds website. So I just very quickly want to thank all of my Healthy Minds colleagues and our many collaborators who are listed here and the organizations that have funded the Healthy Minds Study in recent years. So with that, perfect timing, 15 minutes, I am going to turn to your questions, your comments, your ideas.